I'd like to welcome you to the final session, session 5 of today's program. The topic is mechanisms for comparative oncology trials. I'm Lou DeGennaro. I'm the president and CEO of the Leukemia and Lymphoma Society. I want to thank the organizers and the Institute of Medicine for pulling this program, this wonderful program together. I have to say I learned a considerable amount today. We've got two wonderful speakers. Cheryl London and Amy LeBlanc, who most of you know, but I've only recently met. I thought I'd frame the discussion with a little bit of what we know about the human situation in the hematological malignancies. Patrick, if you could put up that slide. So this is the way the research team at the Leukemia and Lymphoma Society and I think about the hematological malignancies in the patient population we're interested in, people. Each one of the spheres there represents one of the blood cancers, AML, acute myeloid leukemia, multiple myeloma, CML, chronic myeloid leukemia. We heard it mentioned a couple of times. The big purple bubble, non-Hodgkin's lymphoma. The size of the sphere is an indication of the number of new diagnoses in the United States each year. So AML, about 18 to 20,000 new diagnoses, CML, about 4 to 5,000 newly diagnosed patients each year, and non-Hodgkin's lymphoma, about 60,000. The spheres are displayed across the horizontal axis on the basis of median 5-year survival rate. And I've used this as a surrogate for the severity of the disease or the quality or lack of quality of the treatments that we have. You can see that AML persists as a significant problem. The treatments that are currently available are 30-year-old chemotherapies, and frankly, they don't work. Fewer than 1 in 5 patients survives 5 years. As you know, and has been mentioned a couple of times, diseases like chronic myeloid leukemia with the advent of the TKI inhibitors. In the clinical trial setting, 90% of patients are achieving durable long-term remissions. In the real world, you see the data in the United States is not quite that good. It's about 65% of patients achieve those long-term remissions. Just to round it out, the spheres, the bubbles are displayed on the vertical axis on the basis of average age of onset. So a couple of things fall out as you look at it. You see ALL in children versus ALL in adults, and the fact that the majority of these diseases, while they do occur in younger folks, on average tend to occur in an older population for the most part. So this is pretty much the state today, but I wanted to give you some sense of the progress that we've made. This is what it looked like if you map out the SEER data that was available in the late 1970s, early 1980s, late 1980s, early 1990s, late 1990s into 2000s, and back to the situation for today. So you can see we've made, when you look at the median 5-year survival rate, we've made actually some substantial progress in improving the outcomes for patients with these diseases. And as I was thinking about how to frame out today's discussion about comparative oncology trials, what jumped out for me was what's happened in acute lymphoblastic leukemia in children. So in 1963, the survival rate for children diagnosed with acute lymphoblastic leukemia was 3%. 3% in the 1960s. It was essentially a death sentence. Today, 80, 85, nearly 90% of these young children are surviving 5 years and beyond. What happened? In the early 1960s, late 1950s, early 1960s, pediatric oncologists got together and promised to do two things. They promised to put virtually every newly diagnosed child onto a clinical trial, and they promised to share the data together. And that allowed combinations of chemotherapy to be tested in a rapid way. And the rest is history. We were able to make very rapid progress refining these treatments and coming to what we have today, which is this 85–90% survival rate. So we're about to have a couple of presentations about comparative oncology trials, and I think I'd actually like to come back in the discussion to how we might think about the way it was thought about with children, how we might think about it in the comparative oncology setting as well. So the first presenter is Dr. Cheryl London. Dr. London is going to present examples of single institution studies, and I will let her have the podium.